Are you curious about Gestalt language processing? You are not alone. Join me, Corinne Smoose, and speech therapy PD for our podcast, The Gestalt Get Together. Our episodes try to balance the enthusiasm and excitement about GLP and its associated intervention ideas, as well as a healthy dose of skepticism about how to understand and integrate this paradigm shift into your career and the field at large. We hope that you can get together with us to learn more about Gestalts.
Welcome to SLP Learning Series, a podcast series presented by SpeechTherapyPD.com. The SLP Learning Series explores various topics of speech-language pathology. Each season dives deeper into a topic with a different host and guests who are leaders in the field. Some topics include stuttering, AAC, sports concussion, teletherapy, ethics, and more. Each episode has an accompanying audio course on SpeechTherapyPD.com and is available for 0.1 ASHA CEUs. Now, come along with us as we look closer into the many topics of speech-language pathology. Welcome to Season 7, Telepractice. It's not just screen time.
Welcome to the podcast mini-series, Telepractice. It's not just screen time, presented by SpeechTherapyPD.com. Thanks for joining us for episode 11, Best Practices for Telesupervision. This audio course is offered for 0.1 ASHA CEUs. I am your host, Karine Hartunian-Kukean. I've been a speech-language pathologist for over 2 decades with 13 years experience in both special education and healthcare settings. Here are the financial and non-financial disclosures. Karine Hartunian-Kukean is a sole proprietor who consults on telepractice services and works with professionals on accent modification to enhance their communication skills. She is a regional manager at Parallel Learning. She is the host of this podcast and receives compensation from SpeechTherapyPD.com for this presentation. Her non-financial disclosure is that she is the current associate coordinator for ASHA, Special Interest Group for Telepractice SIG-18. Taina Jimenez-Lopez receives an honorarium from SpeechTherapyPD.com for this episode, and her other financial disclosures are that she is a member of the SIG-18 Coordinating Committee. And now here's a little bit about our guest today. Dr. Taina Jimenez-Lopez is currently an associate professor and practicum coordinator at the University of Puerto Rico Medical Science Campus. She is a bilingual speech-language pathologist who primarily provides services via teletherapy to culturally and linguistically diverse school-age children with various communication disorders. Taina received her BA in psychology and MS in speech-language pathology from the University of Puerto Rico. Taina completed her SLP doctorate from Nova Southeastern University in 2020. She has worked primarily in the school setting as a clinician in the states of Massachusetts, Boston Public Schools, and California. Taina worked as a clinical training director at Albizu University and clinical manager at Bilingual Therapies and VocoVision. Taina is a member of the coordinating committee of ASHA's Special Interest Group 18 for Telepractice. She is also part of the board of directors of her state's organization, OPLA, Organización Puertorriqueña de Profesionales Habla Lenguaje y Audiología. Hopefully I said that somewhat correctly, but welcome. We are so excited to have you on the episode today. And before we get started, we would love to hear about your personal journey and how you came to become an SLP and eventually start to do telepractice.
Thank you, Karine, for inviting me. I'm excited to be here as well. And I think every SLP has their own story, right? And mine is not very different from most. I learned about the discipline because of a family member who was diagnosed with autism. And I started attending the therapy sessions and I loved it. I said, this looks really fun. And as I started learning more, I found it very interesting. And kind of diving into a lot of interest areas I already had in the psychology field, specifically language development and just general communication skills. So I ended up doing my master's in speech pathology. I had a high interest in working with school-age children. That was where I wanted to be. I also loved working with adults, and I found it very enriching in terms of it was always different in the practicums, but children were my passion. So I moved to Boston and quickly dived into the bilingual world. Having studied in Puerto Rico, obviously I grew up bilingual, but Spanish was the main language, and bilingualism looks very different in Puerto Rico from what it did when I arrived to Boston. And becoming an advocate to families that were looking for services for their children and an advocate for students who had never had a bilingual SLP serve them, it was really, really special for me. And that's one of the things that drew me to telepractice again. When I moved back to Puerto Rico, I missed working in the schools. Financially, working via telepractice made more sense. So I also was completing my doctorate degree, so I needed extra time in different moments of the day, and that's why I picked California. We have a 4-hour difference, so it tied in really nicely to what I was looking for at that point in my career, and I fell in love with it, finding that I could reach students across geographical barriers. I've never traveled to any of my schools, so I've always been sitting in Puerto Rico and working with students in the state of Washington, in California, and Massachusetts, and making a difference and feeling like I'm doing a good job and I'm successful, and seeing the progress and being able to advocate and support these children really fills me up. So I fell in love with telepractice very quickly, and I've basically stayed there. As I dived in back into academia, I came into supervision as my other passion, and I tied both worlds. Today, we're going to be talking about telesupervision. So it kind of ties along the use of technology to enhance what we already know and what's already in our scope of practice.
Amazing. And I love how you kind of highlighted those typical benefits of telepractice from an SLP perspective, including like using the time zone differences to your advantage. So that's amazing. So our learner outcomes today are as follows. By the end of the course, participants will be able to 1, identify best practices for telesupervision, 2, contrast telesupervision and in-person supervision, 3, apply effective supervision techniques to the telesupervision experience. And I did want to point out that there is a handout with resources associated with this course that can be downloaded towards the bottom of the page on the speechtherapypd.com website. So let's begin with the first burning question. What are considered to be best practices for telesupervision?
So I'll start by defining what telesupervision is, or e-supervision. You'll find both concepts in literature. The literature tells us that it's basically the systematic use of technology to support clinical supervision. So it's taking what we already know about supervision and what's already in our scope of practice and move it into a video conference or using telecommunications to support that. We also have definitions that include terms like synchronous and real time. And that's important because telesupervision does not mean that looking at documents or I'm looking at recordings. Telesupervision still means there's a synchronous connection with the supervisee on the other side, where I'm seeing in real time what they're doing with the participants, patients, or students, depending on the scenario. So telesupervision does not take away that synchronous direct supervision piece of the experience. And kind of setting the mindset on that, we have to go back and think about what does supervision require from us. And ASHA has a very nice position statement on clinical supervision, and it points out 13 tasks that we need to make sure we are doing as supervisors. And all of these tasks can be covered through telesupervision when we are thinking about the technology we're using, when we are considering communication styles, and when we take the time to make an effective supervision experience and plan and make objectives. If we dive into telesupervision, expecting to solve some time problem that you might have, or as a last resource because I cannot go in person and this is the best case scenario, but you don't think about it, you might feel yourself not being successful in meeting these 13 tasks that ASHA outlines for us. The other thing that I like to highlight when thinking on diving into telesupervision is considering your state regulations. So before we say, yes, this is what we're going to do, we need to think about what our state regulations say. Do they allow for telesupervision? Are there any regulations? Do I need a special permit to do it? As well, if you're supervising a clinical fellow, what does ASHA require from me if I'm going to be doing telesupervision? And we'll talk more about that in a bit. But making sure that you're meeting those regulations is going to be key before you move forward. We don't want you to find yourself in a spot where you're not complying with the law and then you're liable for any sort of clinical event and then not have a good time at that point. So first of all, check your laws, both where you're sitting and if you're going to be supervising across state lines or geographical lines, where the supervisee is sitting. You both need to make sure that you're complying with the requirements in that state or country. The other pieces kind of tie along into how we translate our supervision skills into the technology world. I feel it's very similar to telepractice, right? Because as telepractitioners, we're not doing anything different that we would do when we're sitting in the brick and mortar building with our patients or students. But we do have to go through a reflection of how do I translate my skills. So if I tend to do supervisory conferences at the end of my day after supervising a student or an SLPA, does that make sense via telesupervision? After I observe all the sessions, do I want to stay connected or do I want to disconnect, review what I observed, and then make time at an additional moment to do those conferences? And when we have this reflection on how my ideal telesupervision scenario looks, we can then go ahead and plan for the experience. Planning for supervision needs to include objectives. We need to make sure why we're supervising. Are we supervising because it's required by the law? Are we supervising to support the other person in their professional development? Are we supervising because they're graduate students and they're learning the profession, or they're a clinical fellow, moving them towards independence and more of a mentoring relationship rather than supervision? Or am I a supervisor in a SLP group and I'm their lead SLP and I'm just going in to support in making sure procedures are being done in the way that they're indicated by the institution that they're working for, or supporting with a difficult case or mentoring on a specific area? So knowing the objective of the supervision experience is going to make everything flow, and this applies for both in-person and telesupervision. And then planning for those observation sessions. So anything that's going to be direct supervision, we need to make sure it's planned out and that we're making time for it, as well as feedback. One of the complaints of supervisees across the board in the literature is that they don't necessarily receive feedback on the way or manner that they prefer. They feel that feedback is either given in moments where they're not able to really grasp what the feedback is giving them because they're done during a session, or that they would prefer to have a conference to discuss all that feedback, but because of time constraints, it's not happening, or that feedback is not happening at all. And then when you ask a supervisor, they might say, well, I am giving it, but maybe they are not seeing it as the feedback. There might be that confusion about how am I giving the feedback and what is the expectation on the other side. So planning for it will make sure that both ends know When is this happening? When am I providing it? And when are they receiving it? And last but not least, the assessment piece. All supervisory experiences include an assessment of the activities. You might have a formal assessment that is being completed as part of a graduate program, or if it's a fellow, there's a document that as a CF mentor you're going to fill out. If you're an SLPA supervisor, your job might have an instrument that you can use to supervise. If not, there's plenty out there. ASHA has some nice resources to supporting that piece, but there needs to be an assessment. Why? Because the assessment is what will bring the supervisory experience into a full circle, right? So we were doing this because of these objectives. And now that we've gone through this cycle, we're going to assess where we are. Do we need new objectives? Are our objectives still the same? If it's professional development, well, are we taking this to the next level? There's many states that have the requirement of SLPs who supervise SLPAs in supporting them in identifying their professional development hours. And as an SLP, you need to fill out a document where it states that you met and that you're supporting the SLPA in identifying where they're going to find these professional development courses or so forth. So keeping in mind all of that, at the end, when you're assessing, did we meet our goal? Did we make it? And it gives a satisfaction to both ends, supervisor and supervisee. To close all of that, setting clear expectations. And I think this is just basic communication, right? As an SLP, we talk a lot about our communication, but sometimes we forget that we need to set those clear expectations. And in the supervisory experience, it's no difference. With telesupervision, I think it needs to go an extra level since we're not going to be in person in the same building. There needs to be an expectation, a clear expectation of how communication is going to happen. What are the times that I'm available to communicate? How you're going to reach out to me? When are we meeting? How do I need documentation to review it? Or how am I providing feedback? Are we using a Google Doc to keep track of all the data that you're collecting? Am I using recordings? Am I reviewing voice audios or whatever it is? So setting those clear expectations on what's happening in the synchronous manner and the asynchronous manner, or direct and indirect, is going to make everybody very happy at the end of it.
That was wonderful. I do have a couple of questions on what you mentioned earlier. So one thing I think that would be helpful, you mentioned feedback is an area that is supervisees have challenges in that area. Is there any research or anything in the literature about what form of feedback and what feedback is more impactful, effective? I imagine feedback has to be customized according to the personality of the supervisee, but is there like an overall pattern or type of feedback that is more successful than others?
So in general, supervisees report that they prefer direct feedback. And direct feedback is when you're told you're doing this appropriately, this was great, or you need to work on this, and kind of lined out what needs to be worked on. The direct feedback needs to be clear and concise, right? It should not be a hallway comment of great job in that session. That's not considered direct feedback because that's just a praise on something that you observed. So it should be something concrete that you're saying this intervention or the way you handled Johnny during the session when they did not want to continue with the activity, that was great. Continue that. You can also do this and that. So giving them the context of it is what most supervisees report expecting. There's been some research where they've expressed that they like written feedback, which for telesupervision works very well. I've had the experience of using written feedback after observing a session on a synchronous meeting. I observed the session and then I let the supervisee continue what they're doing, their dates. It's been with SLPAs. And I provide written feedback. I send an email with what I saw, what I think was done well, or if there's any changes that I recommend. And then at the end of every week, we would have an synchronous meeting, just the two of us, to discuss what happened that week, what we observed, what are some changes that need to be made, what are some recommendations that I have to work differently on a student or to continue working on those. Tied to that, I used the Google Documents to kind of both be inputting information, because these were students that we were both seeing. The SLPA saw them sometimes of some of the sessions of the week, and then I saw them some. So for our data to be together, we collaborated there. But it was clear what we expected, and my SLPA appreciated that I wasn't holding her after sessions to give her my feedback. She could just read it, and then we had that one meeting where if she had any questions or comments on my feedback, we could discuss it. So that's something that I know it's come out as a preference. But again, like you mentioned, it depends on the person. Also, generationally, their generations might prefer feedback in different generations, might prefer feedback in different ways of wanting to meet in person to get the feedback, or just receiving the email is enough for me and I'll work from there, as well as just general personality traits.
And then I wanted to talk a little bit more about the assessment process, because that's also a form of feedback, right? It's the other side of the feedback on how the whole supervision process is going. Could you explain that a little more for those that may not have done supervision in general or are new to supervising? Is that something that would be done throughout the process or at the very end of the process? And what are some typical questions, or how would you go about doing that? Is it through a survey? Just curious if you could explain that.
Definitely. So the assessment is that way again of making sure that the objective of the supervision is being met, right? I'll give examples of different types of supervisory experiences, starting with students, right? So graduate students. For most of these, you'll have a formative assessment and then a summative assessment. I'll expand more on that. So for a student, the objective is that they're learning, right? They're taking everything that they took from their courses into the clinical practicum, and they're starting to learn how to manage a patient, how to implement goals, how to write goals, how to review a medical record, and so forth. So the assessment for a graduate student will mostly be divided into the sections of the skills that I'm working on them. So I'll have a section on assessment. Are they able to select the correct assessment tools? Do they understand how to implement theory into an assessment to make a clinical judgment and make a diagnosis? How was the discussion of the assessment results? Were they able to make a diagnosis independently? And most of the scales for this assessment will run from does it independently, needs some support, most support 50% of the time, or just could not do it, needed modeling throughout. Obviously, a student that's in their first practicum will expect to need more support. Assessments are supposed to take that into consideration. So the same grade at your first practicum should not mean the same as if you got that grade in your last practicum. I expect growth, right? And that's why you have that formative assessment and then summative assessment. Let's say you're working with a CF. So the CF, we want them to gain independence. So their assessment might not go so in depth into each of the sections. It might be more general. So when I'm discussing interventions, is the CF able to give me justification for the model of therapy that they're using? That sort of thing. So more of that next level knowledge that evidences independence as a clinician, right? It might be talking about interprofessional relationships. So is the CF collaborating with other clinicians at the site that they're working at? Are they able to handle their caseload and that sort of thing? It looks also at their writing skills and so forth. All of our scope of practice should be part of that assessment, but in a different level. Now, we think about an SLPA. So this is a professional who's licensed as well, but why are we supervising them? And it's because we're sharing the caseload, right? So we are both in charge of these students, and we're working together to ensure that the student receives the best of the services. As the SLP, I'm developing their treatment plan and I'm driving the train. So I'm saying, this is where we're going. This is what we are working on. And my SLPA is on the train with me, following my lead. So if the supervision has to be around making sure that they're still on the train with me, that they've not left the track and working on something else, or using an approach that's not the one that I consider to be most appropriate, and that they're understanding as well where they're going. And that's why most states have that piece of the SLP supporting the SLP in identifying their professional development courses, because I want them to develop those skills based on obviously the scenario we're working. So if I'm working at a pediatric dysphagia clinic, so I want to make sure that my assistant understands what are the needs of my patients and that they develop those skills. If I'm working at a school, I want to make sure that they have an understanding of the disorders that we're going to be encountering. And again, get the information around the approaches that I'm using. I'm driving the train, selecting approaches, selecting the treatment plan, but they're behind me and I'm assessing all of that. When we talk about the assessment, I mentioned you have a formative assessment and then a summative assessment. And the reason is because as we start the relationship, the supervisory experience or that supervisor-supervisee relationship, we establish goals. And that formative assessment lets us know if we're on the right track before our term ends. For graduate students, that might be midterms, right? So we have a formative assessment during midterms, and then at the end of the semester, we have a summative assessment and they get a grade. For a clinical fellow, ASHA recommends 3 check-in points. So there's these 36 total hours that they need to be supervised, 18 direct, 18 indirect. It has changed a little bit how ASHA organized it, but it used to be that you have 3 segments, right? And you had like a check-in at each one of those, and each one of those check-ins was your formative assessment, was a way of letting you know if you're reaching your goals, where do we need to make changes, or how do we attain that independence level that a clinical fellow should have at the end. And when we're thinking about the SLPA, we might think about the year. So we're going to be together for this school year or for this calendar year, and every certain amount of weeks or month, and that can be determined either by the state. Sometimes states have regulations about when those need to happen, or your job site. A corporation might say the expectation is that this person is assessed every 3 months or every semester, and then you implement that and you have that formative piece before the end one. Your summative assessment as a supervisee is what lets you know, am I making it? As a student, am I going to progress in my practicum and be able to graduate? As a fellow, am I going to get my C's? And as an SLPA, basically, am I going to continue to be able to work, right? It's a way of knowing if we are implementing our clinical skills appropriately, or if there's any areas of need that we need to tend to. For SLPAs, that supervisory relationship will change over time. Again, because they're professionals who are licensed as well, went to school for this, have gone through their own practicums and so forth. So a seasoned SLPA, the supervision might be more of a collaboration between the SLP or a mentoring, right? Between the SLP and the SLPA in making sure that we are both on the same page on our treatment plans, more so than professional development piece. And we take, again, that into consideration where we're doing assessments. Supervision can also happen as the lead of a team, right? And most jobs or institutions, corporations have their own assessment instruments. I recall working in the schools and the lead SLP for my district coming and observing me and providing an evaluation results for me and recommendations of, I love this. I think your planning was excellent. I would implement this, and giving recommendations. Some people might feel attacked when these evaluations happen, But a supervisor, the way I see it is I'm supporting you and continue growing. I feel like SLPs and no professional, although I'm sticking to our profession, but it applies in general. But we never stop learning, and there's always something that we can improve. I might have the most knowledge in an area or the most preparation. I might have certifications and so forth, but there's always something new coming out, right? So there's something new that I can learn or that I can implement or that I can change. I think being in this world of the technology piece of our clinical practice keeps us in that innovation of how can I continue enhancing my experience. I know not everybody's on that train, but thinking about assessments in that way of this is keeping me on track, this is keeping me innovating, is a positive way of receiving that feedback.
That's a really, really good point. So I think let's dive a little bit deeper into the different types of supervision and specifically what tasks fall into each supervision type, direct and indirect supervision, for example. And is there a difference with what ASHA states compared with state by state rules?
Excellent question. As I mentioned in the beginning, right, both always check both. I'll start with what ASHA says. So ASHA tells us that direct supervision means an in real time observation and guidance while the supervisee is performing a clinical activity. It does not include watching a recording, even though right? We're seeing someone do something, but it should be that live in real time synchronous activity. That's what direct supervision is considered. ASHA tells us that telesupervision is direct supervision, or direct supervision can include telesupervision, better said. But this will vary state by state. For example, right now we have the example of California. They've already approved the regulations for RPEs, but for SLPAs, they're still on the works, right? They're proposing that telesupervision be allowed. That hasn't passed. I think they had a meeting just as recent as February 4th or 3rd. But the idea is of that requirement of direct supervision that the state has written in that clearly defines as in-person supervision and so forth, that it can include telesupervision as ASHA tells us, right? And many states are moving towards this based on what we experienced during the pandemic and really seeing that telesupervision works, that it met the requirements of meeting those expectations of the supervisor, of being able to observe, being able to provide feedback, being able to be present during these sessions, even though I'm not in the building. In that sense, it also has given that opportunity of higher productivity. Because if I don't need to go into the building to see my SLPA every week or every other week or whatever requirement there is of supervision, and I can continue doing other things on my end and take away that travel time, it benefits both ends, right? So telesupervision is a model of or a method of doing supervision that is found to be effective and also supported in other areas beyond just what the supervision experience is. Now, indirect supervision, it's the monitoring or reviewing of activities outside the direct services. So we're talking about documentation, we're talking about planning, we're talking about data collection. I mentioned previously with an SLPA I supervised, I kept a Google Doc where we were both inputting our data collection, and then later we could review and we could see discrepancies of, okay, so this is what I collected, yours looks different. How are you collecting your data, or so forth. Indirect supervision could also be reviewing progress reports. So going in and seeing how does this compare to what I have from my observations? What are you reporting? It can be reviewing plans, therapy plans, if that's something that is required. For students, for example, it will mean reviewing all of their documentation before it goes out anywhere. In the hospital setting, a supervisor needs to review all notes before they're put into a medical record. That indirect piece of where the supervisee is no longer with a patient and you're not necessarily together, will require the supervisor to get access to that. So when we're thinking about telesupervision, we need to make sure, how am I accessing all this documentation? How are we sharing this information in a, again, confidential and secure way? So direct and indirect supervision are obviously all pieces of the supervisor experience, and they're needed and expected within both state regulations, ASHA regulations, and your institution regulations. There's an expectation of you're going to be seeing this person when they're in direct contact with a client or a patient. So that clinical activity needs to be supervised in a direct form. And that goes across the board through all scenarios, right? But there's also the expectation of the indirect, which will mean that you're reviewing every other piece of the administrative piece that's so high on many of our scenarios, to make sure this person is, again, completing the work in using the correct language or selecting the correct approaches and so forth, depending on the level of supervision that is needed. In all of these scenarios as well, as a supervisor, it's important that I see the importance of that indirect supervision, because our license as supervisors is tied to my supervisee's work. So anything that goes out there from my supervisee, it's implied that I reviewed it and that I saw it and that I approve it. So if I'm the SLPA's supervisor and the SLPA is sending this document home or giving out this progress report, it is assumed and expected that the supervisor approved that. So as supervisors, we need to make sure that that indirect piece is happening in a scheduled manner so that nothing gets unreviewed, right? And that we have a set way of how I'm accessing the information and how I'm giving you feedback so that you correct whatever I need you to correct. And I think with students, this is a very demanding job of the supervisory experience, where you need to review all the reports, all of their notes, daily notes. And as the supervisee develops skills, it gets easier, right? But during graduate school, it is one of those high important tasks that the supervisor has. As a CF, I think most of all can recall, our supervisors or our mentors did not look at every report that we handed in. And there might be a scheduled way of sending them. The CF mentor might say, during this first month, send me all your reports. And then during the next segment, I just want to see an example of one or two. And that will, again, vary between individuals. If I see that this person is gaining independence, I just want to see examples of what their work looks like. However, some states, the clinical fellow or RPE, depending on what state you're in, is tied to your license. So in those scenarios, I will suggest that you look at everything and not pick and choose. It will vary, but making sure how tied your license is to your supervisee will make it clearer to you in deciding how you're doing that indirect supervision of documentation.
So I have to ask this question because I think it's very important. What can you do if the state is not clear about regulations and basically telesupervision falls into a gray area?
That happens more frequently than we would want, right? There's going to be a link to a map that has colored in the states that have regulations and which ones do not. And you can access it. It's in the links that I provided, and it's created by ASHA. But if your state does not have clear regulations, or it's just that gray area where it mentions telesupervision, but there's no exact guidelines as to how many hours of telesupervision are accepted, or if you can do it with SLPAs, but not CFs and so forth, or you can do it with students, but not with SLPAs, all those variations, I would suggest to take the literal interpretation and call your board. So if it just says you can do telesupervision, call your board and ask, so can I do telesupervision with my SLPA? And ideally send emails so that you get an answer in writing. That's an option. If they cannot provide confirmation in writing, I would suggest not to risk your license. Again, because as we've been talking, when we accept the role of supervisors, we are accepting that our license is going to be tied to this person's work and that we are recognizing our responsibilities as supervisors. So we're going to be liable for anything that happens. And if there's any gray area around the acceptance of telesupervision in a certain scenario or with a certain individual, and thinking students, CFs, or SLPAs, then you're liable and you want to prevent getting into any legal problems. If telesupervision is the last resource, so it's either we do telesupervision or there's no supervision at all, my suggestion would be call your board, write a letter, make a statement, and let them know that because of the lack of regulations, this person is going to go unsupervised, or you're going to lose someone who's providing services, and that if they leave, there will be no services. And that tends to move things along, right? When we say we're going to take away services when clients, patients, students are being affected, there tends to be a high interest in making sure that that does not happen. Use your state representatives, talk to ASHA, and it's in this scenario where this is the last resource. There's no other option but telesupervision. I suggest you go that route.
Thank you. That was very helpful. Let's talk a bit about logistics. Again, telesupervision, that whole experience can be very different depending on how the equipment is set up and how all of those things are agreed upon. So what are some best practices for setting up equipment and the platform to use?
So similar to Telepractice, right? You're going to need your computer, a camera, nice microphones or headsets, depending on the space that you're using, a private space, definitely. What will vary is the setup at the client side, right? So if I'm doing telesupervision under a telepractice model. So my supervisee is providing services via telepractice, and we're all connecting into a telecommunication meeting in whatever platform you're using, then definitely making sure that I have a good view of the student and the supervisee. Supervisors tend to introduce themselves and then put their cameras off and kind of stay behind the scenes in the virtual room. But what if I'm doing telesupervision and it's not a telepractice session? I'm using telesupervision just for the sole purpose of supervising, or telecommunications for the sole purpose of supervising and not providing the services. Then I need to make sure that in that therapy room or in that office, the camera provides a nice view of the table. If it's a group session, I want to see every student. I want to make sure that there's a good microphone that picks the voices from everyone participating in the session. So I'm not just hearing my supervisee who's close up to the computer. So you might want a conference microphone that pulls out and can stand in the middle of the table. There's technology now of cameras that move around the room so that they capture the person who's talking. These might all sound very expensive in order to meet these requirements. But as we've been talking about, doing telesupervision does not take away this responsibility of meeting the scope of practice of a supervisor, right? We need to be able to hear everyone, see everyone, understand what's happening. I should feel like I'm in the room, or as if I were sitting in the room supervising. So the experience should not feel any different. And that in many occasions will require investment in technology. Same thing happens for telepractice, right? It's not a cheaper way of providing services. In most occasions, there's a big investment in technology to ensure that we are providing the best services. The other piece and when we're thinking about telesupervision is what platform are we using? So am I joining them in their telepractice session? So are they using a HIPAA compliant platform? If I'm working in the schools, I need to take into consideration FERPA, high tech, and so forth. So making sure that the platform that you're using still meets all of the privacy and confidentiality regulations and laws. Why? You might think, well, if I'm only observing the session, I might just call on FaceTime. Well, you're still going to be sharing some personal health information through sessions. There's going to be mention of the names. There's kids that are present during the session if it's in a school. There might be a patient who's receiving the service. All of these needs to be through a safe and private, confidential mean that cannot be taken in lightly. In addition to that, there needs to be consent for all of this. The same way we take consent for services, consent for telepractice, if that's the situation, there needs to be a consent that a supervisor is going to be joining virtually through X platform to supervise this clinician. And this goes across the board in person and telesupervision. The patient and the parents or guardians of patients need to know that this person is under a supervisory process, be it that they're a student, they're a CF, and in case of SLPAs, that's more of, I don't want to say common knowledge because it's not necessarily common knowledge, but if there's an SLPA in the school has already informed families, right? SLPAs are providing services, but there's a consent to knowing who's servicing my student and if there's anybody else joining in during these sessions. And it's that piece of privacy and confidentiality. We cannot forget to make sure, beyond what I've been repeating across our conversation of making sure you're following the laws and regulations around telepractice, you need to also make sure that you're keeping on track with anything that's privacy and confidentiality. That includes emails. Sadly, right now, we communicate mostly electronically and not everything is safe. So making sure we're safe in all of our technological realm is going to be highly important.
And so you touched upon the similarities and differences a bit, but let's talk again about how does telesupervision compare with in-person supervision? And if you can just briefly highlight some similarities and differences.
Yeah, they are similar in terms of what the supervisory process is, right? You need to have objectives, do planning, do assessments. That's not going to look any different in terms of what are those check marks that you need to take across the experience. Expectations are not going to change. If I'm supervising a student, I'm going to expect the same things from them in person that if I'm doing telesupervision. Why? Because there's objectives that need to be met under class syllabus and so forth. Same thing for a clinical fellow, right? There's standards that ASHA has stated that need to be followed. And as I'm going into this experience, those are my expectations. Those are my goals. And the requirements of that direct and indirect that we've been mentioning, right? There needs to be direct and indirect experiences across any type of scenario of in-person or telesupervision. Now, how we develop our relationships in telesupervision is going to look different, mainly because we're not seeing each other in person. There might be the scenario where we've met in person a couple of times and then we're going to do everything else through telesupervision, and that helps. But if we're only meeting virtually in the virtual world, we need to make sure that we take time to develop that relationship more so than when we do it in person. Because when you're in person, there's moments where that is going to naturally happen. We're in the virtual world. If we do not take the time and I just join in, observe you, great, send you an email, good, this, that, and keep it all technical, the relationship might take very long to develop or might not develop at all if the experience ends before it develops. And not developing that relationship between supervisor and supervisee will affect down the road how well feedback is received and provided as well. It will affect the assessment at the end, because if I have no connection to this person and just keep it at a very clinical and technical content, I might be losing and disregarding some skills that the person might be not showing me while I'm in that virtual space in that moment. Supervisory conferences are going to look different just because there is going to be a component of scheduling that typically in person happens naturally. So if we're both in the clinic and we say, let's just stay longer today, or we plan on Thursdays and we join in and kind of have other things happening, we're in the same space, things tend to flow differently. When we have to schedule and make time for it, there needs to be that compromise that if I'm going to be connecting for this, I expect you to be there and so forth. To me, the biggest difference between both is the way communication happens and the manner that the supervisor needs to be very explicit about expectations. I tend to find that when supervision happens in person, there are some moments where supervisors do not see the high importance of expressing their expectations. It just happens down the road. So as things come up, they'll say, oh, I wanted this way, or I wanted this way. But when you're doing telesupervision, you cannot wait for things to happen down the road because everything requires extra planning. So to me, it pushes everyone to communicate more efficiently to prevent issues later.
So I can't help but ask about any tips on generational differences we've all kind of heard about. Any comments on that?
Right now, I think we have boomers, we have Gen X, we have millennials, Gen Z, and the alphas are coming out. They're in the universities right now. So we have all these groups of very different people that see life in different ways, because that's right how you could put it. They have expectations about work that are different from each other. We have our Gen Z that right now are coming into the workforce who are expecting very flexible schedules. They want to have their own spaces to kind of be themselves and share their thoughts and so forth. And previous generations saw the workplace as a space where I come, I do what I have to do. I don't necessarily expect anything more from my work than just going to work, right? There's studies now that are saying that the Gen Z, they look into what a company is doing in terms of their volunteer work. If I'm thinking the word in Spanish, I'm sorry. You're like, oh, what's the word? Aportar. If they're providing anything to society, if they're doing anything to give back. And if they're not, they see that as a bad thing and they keep going and they're not afraid of just saying no to this job and waiting for the next. Previous generations, they looked for that security. They appreciated having stability. And millennials and Gen Zs, they tend to fluctuate more. They're not willing to compromise certain things about their lifestyles in order to meet the requirements of a corporation or of an entity. So in that sense, when we're supervising a generation that's different from ours, the invitation is to learn about that generation first, right? So look into it, do a Google search, see what is said about this group of people. You might find that the person fits right in and you're like, yes, that's them, or that they are fluctuant and not necessarily meet all of the check marks for that generation and generation's description, but learn about it. And as you learn about it, thinking, how is that going to affect me? How do I feel about someone who is expecting a great amount of flexibility from my end. Can I be that flexible? Or do I need to set a boundary and say, hey, I'm flexible up to here, but there's some things that you cannot do beyond this line? This brings me to think about how younger generations relate to other people. So think about how are they discussing a report with a parent and letting them know that their child has a disability. So how serious you take that conversation. And I'm not saying that younger generations cannot be serious, but how familiar do you become with this family? How you create that rapport? Or do you just go in and give them like, this is what it is, and we're going to do therapy? And we see a little bit, and again, these are personality traits as well, but thinking about how those generational traits might affect those relationships, and what are some things that I put in boundaries. You cannot become friends with the parents of of our patients, or you need to be respectful when families come in. You cannot have your phone out with a podcast as they are, coming into our clinic, and you're in the, desk working on notes or whatever it is. And same thing for older generations, as we receive newer generations. So there's a lot of talk about the way the way we dress. So an older generation might feel like, oh, that's not necessarily appropriate. But for younger generations, there's I'm not sure if this is a word, but it's more permissible, the range of clothing that you can wear. And for example, here in Puerto Rico, and I think it's general, but I'll talk to what I'm familiar with. Most universities have moved to have students wear scrubs because it keeps uniformity, and takes out opportunity of personality traits to be expressed through clothing. And it's why uniforms exist, right, across the board. But in the past, for example, when I went to school, there was no uniform. We could all we were asked to wear professional attire, and to us it was clear. No one needed more examples of what that was. But as new generations come up, there's more lax understanding of what that is. I don't know if the pandemic has to do with it or what it is, but those are the sort of things. And so for an older clinician, and they might feel like this is not appropriate, what's the boundary? But also think about, well, times are changing. This might be okay. How do I feel about this? And do some self-assessment. And that is a key piece of supervision as well that I haven't mentioned. We both need the supervisor and the supervisee to do self-assessments. And as we're talking about generational differences, that is one piece that we need to look at it, to look into, but also cultural and linguistically diverse populations. So if we have a supervisee that's from a different culture to ours, making sure that you're taking a step back and reviewing your cultural competence and saying, how am I treating this? Am I being accepting? Am I being flexible? Am I just crossing a line that I shouldn't? And so forth. So am I making, comments that might be considered gaslighting? And it can happen. So doing that self-assessment is going to be key as well to making sure that these barriers that we might find because of generational differences and so forth do not interfere with why we're here, which is the supervisory experience.
And Taina, believe it or not, we're very close to the end of our time, and we still have a lot of questions to answer. But what I'd like to do is wrap up with our final main question, which was, how can a provider apply supervision techniques most effectively to the supervision experience? I know we'll put a lot of these additional resources into the handout, and they will be available to everybody.
How can I apply my supervision skills to telesupervision? I say first thing, think about your supervision styles. Think about what you already do. So do you use a directive style? Do you use reflective practices? Where do you find yourself within the supervision style world? What model do you tend to use, or do you use a mix of models? Once you know which model you use, you'll understand what your technology needs will be. So, for example, there's a high-end technology where as a supervisor, there's that in-ear piece, and I'm observing what's happening. My supervisee has an in-ear piece, and they can hear me, but the students or the participants or patients cannot hear me, and I'm still able to provide that feedback or direction to my supervisee and so forth. So depending on my style, I will think about technology as well as the scenario. What do I need in that space? And then previous to getting started with anything regarding the direct or indirect supervision, there needs to be that supervisory conference where we talk about our expectations, we plan on how we're going to communicate, we schedule our meetings, and we make sure that we are both on the same page on our compromise on connecting for these synchronous meetings, providing that indirect supervision, providing that feedback. How are you receiving that feedback? How do I know what your thoughts were on that feedback? All of that needs to be discussed prior to getting started. And then selecting the communication method that works best for both ends. So how are you going to reach out to me if you need me during the day? Is it going to be a text? Is it going to be an email? Is it going to be a phone call? If there's an emergency, these are the steps that I want you to follow. If you need me right away, you're going to call here, this, and do that. If for feedback, we're going to communicate through email, or we're going to do it on a once a week Zoom meeting or so forth. So taking all of those pieces will help you feel successful and effective when you're transitioning to telepractice. If you're not able to identify your supervision model, I invite you to take a step back and do that self-evaluation. So what do I do? And then go and review. ASHA has a lot of resources. Go in the position statement. They have not in the position statement, in their practice portal, they have nice resources in terms of identifying, and you might not know the name of it, but you might say, oh, this sounds like me. I think this is where I stand. And knowing that, you'll know if you want to give that in the moment real-time feedback, or if you're more of that reflective where I'll leave you with questions and we'll meet later to get some answers, or how are those supervisory interventions happening?
Thank you, Dr. Taina Jimenez-Lopez. We truly appreciate the research, education, and expertise you provided about telesupervision. We'll see you again next time at another speechtherapypd.com course.
Thank you for joining us for tonight's course. To complete the course, you must log into your account and complete the quiz and the survey. If you have indicated that you're a part of the ASHA registry and entered both your ASHA number and a complete mailing address in your account profile prior to the course completion, we will submit earned CEUs to ASHA. Please allow 1 to 2 months from the completion date for your CEUs to be reflected on your ASHA transcript. Please note that if this information is missing, we cannot submit to ASHA on your behalf. Thanks again for joining us. We hope to see you next time. Thanks for joining us at SLP Learning Series. Remember to go to speechtherapypd.com to learn more about earning ASHA CEUs. We appreciate your positive reviews and support and would love for you to write a quick review and subscribe. If you like this and want to hear more, we are offering an audio course subscription special coupon code to listeners of this podcast. Type the word SLP Learn for $20 off. With hundreds of audio courses on demand and new courses released weekly. It's only $59 per year with the code. Visit speechtherapypd.com and start earning ASHA CEUs today.